Today we'll discuss infections. First, we'll see the childhood exanthems, the named diseases. So these are actually fever with rashes. Okay, so these are cutaneous eruptions, which are called exanthems. Ananthem, on the other hand, means mucosal eruptions. So exanthem means fever with skin rash. So the first disease is measles, caused by measles virus, which is a rubeola virus, or um, it is a paramyxovirus family. The main symptoms are cough, coryza, conjunctivitis, and we have a classical feature called Koplik spot, which is seen in the buccal mucosa. And again, we have vaccine for measles, which is MMR given at 12 months, then repeated at 18 months, 2 doses. Next is scarlet fever. Second disease, scarlet fever, caused by Streptococcus pyogenes. It's all S, okay? Second, scarlet, Streptococcus pyogenes. It has classical sandpaper rash, pastia lines, and others which we'll discuss later. Third disease is rubella. So first disease is rubeola or measles. Third disease is rubella or called German measles, caused by rubella virus. In children, it mainly causes lymphadenopathy, fever, rash. But in congenital rubella, when it affects the mother during the intrauterine life, it is more severe, can cause cataract, deafness, and cardiac defects. That is the triad of congenital rubella. Then fourth disease is no longer accepted as a distinct disorder, so it is not named. Fifth disease is erythema infectiosum caused by parvovirus B19. This has been asked in some questions. So it is erythema infectiosum parvovirus B19, which is sixth disease. Now, sixth disease is roseola infantum, which is caused by HHV 6 and 7, that is human herpes virus 6 and 7. It can lead to febrile fits also because it is high grade fever. Okay, now coming to measles, it is first disease. It has morbilliform rash. That is the description of rash given in measles, morbilliform rash. And there is cough, coryza, conjunctivitis. It is a paramyxovirus, so there is conjunctivitis. Okay, and there is exanthem with fine desquamation after 4 to 5 days. There are many complications of measles. One of the rare but serious complication is subacute sclerosing panencephalitis, which happens 7 to 8 years after the onset of measles. And along with measles, you can have measles encephalitis and other complications. Exanthem, it is an exanthematous rash, which is called morbilliform rash, but there is an enanthem, which is a mucosal rash on the palate, on the buccal mucosa, that is called Koplik spot. Okay, on the second upper molar, that is a classical site. Then we have maculopapular blanching or partially confluent rash. That can be generalized lymphadenopathy as well. Okay, and there is cough. So cough, coryza, conjunctivitis with rash and an enanthem called Koplik spot. There are many complications, but one of the rare and more important one is SSPE, subacute sclerosing panencephalitis. Okay, and the contagious period is from the starting of this fever to the onset of exanthem. Okay, the incubation period is around 5 days. Contagious period is from that incubation period, that is mainly up until the onset of exanthem. So again, rubeola is your ordinary measles first disease. Rubella is German measles, which is third disease. Roseola infantum is your sixth disease, caused by human herpes virus 6 and 7. It can cause febrile fits as well. Here, what is more important is only after the fever subsides, rash will develop. So if the description is saying that there was a high grade fever, after that settles, you have a rash, think of roseola infanta. Okay, affects 6 to 36 months old, so very young children. The rash starts from the neck and trunk and spreads to the face and extremities. But in rubella, usually it starts from the face and then comes down. In measles, it starts behind the ear and then spreads cephalocaudally over 3 days. Okay, there is cough, coryza, conjunctivitis, and fever with Koplik spot on the buccal mucosa. In rubella, usually you have lymphadenopathy. The spot on the soft palate is called Forsheimer. So this is the enanthem seen in rubella. There is headache, low-grade fever, sore throat, and coryza. Rash begins on the face and spreads cephalocaudally. So in measles, behind the ear, rubella on the face, roseola infanta neck and trunk, and then it spreads to face and extremities. So that is roseola infanta, which was sixth disease. This is fifth disease, erythema infectiosum, which is slap cheek appearance caused by parvovirus B19. Okay, this is a lacy rash or slap cheek appearance. Again, famous maculopapular childhood rashes. You have seen roseola, which is a Chichwi 6. It is non-pruritic. There is high fever. After the fever settles, you have the rash. It usually starts on the neck and then spread to face, neck and trunk, and then spread to face and extremities. Complications are febrile seizures. Measles, it is morbillivirus or morbilliform rash. Okay, again non-pruritic. Starts behind the ear or on the face. There are 3 C's: cough, coryza, conjunctivitis. There is Koplik spot. And the complications include secondary bacterial infection, encephalitis, and subacute sclerosing panencephalitis. It is very rare, 1 in 10,000, 1 in 100,000 cases, but it is important. Rubella, it is very pruritic. There is lymphadenopathy, there is rash. Okay, congenital rubella, it is very bad. In the first 4 months of pregnancy, carries the highest risk, which is classically seen as a blueberry muffin rash with cataract, deafness, and cardiac defects. Fifth disease or erythema infectiosum caused by parvovirus B19. There is a slap cheek appearance. Okay, may appear on the extensor surface. Again, non-pruritic. Complications include arthritis and vasculitis. Okay, so parvovirus has arthritis in around 10% cases. This has been come as a question. So after parvovirus, the child is coming with joint pain. Think of post-viral arthritis-like illness. There can be a plastic crisis, vasculitis, and during pregnancy it can cause fetal high drops and fetal loss. Again, chickenpox, it is very, very pruritic. It can be seen anywhere. Vesicles on macules, that is called dewdrops on rose petal appearance. Okay, congenital, also it can cause congenital varicella syndrome. In 1 to 3 day prodrome of fever and respiratory symptoms. After that, there is complete rash. And usually the infective period is until the last of the rash has crusted out. Until then you have to keep the child in isolation. Do not send them to school. And the description of the rash is dewdrops on rose petals. Now we'll see what is Kawasaki disease and what is scarlet fever. So scarlet fever is second disease. You have seen that it is caused by streptococcal infection. The fever responds to antipyretics, and there is tender adenopathy. The rash blanches. There is fine papillae and pastia lines. It can be verified by rapid antigen test or culture, treated with antibiotics because it is a bacterial infection by Streptococcus pyogenes. It can lead to rheumatic fever and post-streptococcal glomerulonephritis as a complication of the streptococcal infection. Now, what is Kawasaki disease? It is fever more than 5 days with a bunch of other symptoms, which can be cervical lymphadenopathy, edema of the extremities. There can be strawberry tongue. Okay, and there can be a rash. Okay, but it can also affect the heart. That is why you have to always do an echo in the setting of Kawasaki. So when you diagnose the disease as Kawasaki, you have to always do echo. So there is fever which is not responding to antipyretics. There is painless adenopathy, non-specific polymorphous rash, and the main line of treatment is aspirin and IVIG. So this is one case where a child could be prescribed aspirin. Children are usually, uh, you know, not given aspirin due to the fear of development of Reye syndrome, which is encephalopathy, hepatitis, and all, with the introduction of aspirin. But Kawasaki, you have to give aspirin and IVG to reduce complications like coronary artery aneurysm. That is main complication seen with Kawasaki. So diagnostic criteria of Kawasaki is temperature of 5 days with 4 of the other features, which you can remember like my heart, that is mucosal involvement, which are cracked lips, strawberry tongue, injected pharynx, etc. Hands and feet, you can see edema, desquamation, redness. Eyes involvement, which is non-purulent bilateral conjunctivitis. Adenopathy, usually unilateral cervical lymphadenopathy. Rash, it is polymorphous truncal, which is a scarlet fever like rash itself. So there is some difference, some similarity, but more difference between scarlet fever and Kawasaki because treatment line is different, the entire presentation is different, the complications are different. Treat with high dose IVIG and aspirin. The complications include coronary artery aneurysm and coronary artery vasculitis leading to MI. Steroids are of no help in Kawasaki, and it actually increases the aneurysm formation. So in Kawasaki, do not answer steroid. It is not a treatment of choice. Okay, remember it like my heart, which is mucosal involvement, which is strawberry tongue, cracked lips, hands and feet, edema, erythema, and desquamation, eyes, bilateral non-purulent conjunctivitis, cervical lymphadenopathy, and rash. Okay, treat with high dose IVIG and aspirin. Aspirin is only used for Kawasaki in pediatric in the fear of a rare but serious condition called Reye syndrome. The exact mechanism is unclear, but Reye syndrome results from mitochondrial injury and fatty degeneration in fatty degenerative liver failure, which leads to hyperammonemia and encephalopathy. So again, Kawasaki, you have high-grade fever, you have strawberry tongue, red lips, cracked lips, conjunctival redness, which is non-purulent. There is cardiac complications in 5 to 20% cases, which is mainly coronary artery aneurysm. And there is rash, there is red soles and palms, and edema also, peripheral edema, usually in children less than 5 years old. Superficial skin layers desquamate easily, and there is cervical lymphadenopathy. There can be occasional intermittent colicky abdominal pain associated with MI, which is another complication with Kawasaki disease. Now, scarlet fever, it is a delayed type hypersensitivity reaction to pyrogenic exotoxin produced by Group A streptococci. Group A beta hemolytic streptococcus is the positive organism. After 1 to 2 days, there is confluence and scarlet red discoloration of exanthem. After 1 to 3 weeks, there is desquamation, peeling of hands and feet. It is called sandpaper rash, and the complications are acute rheumatic fever and post-streptococcal glomerulonephritis. Antibiotic of choice is penicillin. So there is maculopapular rash, cervical lymphadenopathy. Pastia lines means mainly in the axilla and groin you can see rash. That is called pastia lines. There is flushed face with perioral pallor. There is an anthem of soft palate, initially white coating on tongue. Strawberry tongue also seen, but the lips are not usually involved. That is the difference between Kawasaki and scarlet when it comes to the oral mucosal involvement. So how to spot scarlet fever? There is fine red rash, feels like sandpaper. White coating on tongue that peels after a few days, leaving it swollen and red. That's called strawberry tongue. So initially there is white coating. There is fever, which is high grade, flushed red face but pale around the mouth, and swollen glands on neck. So cervical lymphadenopathy. Now a word on hand, foot, mouth disease. okay, which is caused by usually by Kawasaki virus. It is a rash with blisters and sores that usually forms on the child's hands, feet, and mouth. There is mucosal involvement as well, and child may be unable to swallow solid food. So during that time, you may advise to give soft liquid diet. And usually there is rash, and it can again desquamate. Now coming to EBV. EBV is the causative organism of infectious mononucleosis. It is a human herpes virus. So I'll just remind you what is human herpes virus class. So we have HHV1, which is HSV. Okay, HSV. HHV2 is also HSV. So human simplex virus 1 and 2. Okay, 1 is usually associated with the oral lesions, 2 with the genital lesions. Then we have 3, which is varicella virus. Okay, the activation of varicella is called herpes zoster. So 4 is EBV and 5 is CMV. CMV. So 4 is EBV, 5 is CMV, and 6 and 7 you have seen it is causing exanthematous fever in children. 6 and 7. 8 is your Kaposi sarcoma associated virus, usually causing Kaposi sarcoma in immunocompromised like HIV. So that was human herpes virus. So EBV is human herpes virus 4. It causes kissing disease. It is a great imitator because the presentation can be non-specific. The diagnostic test is called monospot test or heterophil antibody test. Complications can be splenic rupture and GBS. Okay. The pathological sign is called downy cell. Okay. It is also said to have a ballerina skirt appearance. So main high yield points are it is kissing disease, HHV4 can cause infectious mononucleosis, and other cancers like nasopharyngeal carcinoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, Burkitt lymphoma. These are the main cancers associated with EBV. There are also some gastric carcinoma. Okay, Hodgkin's, non-Hodgkin's, nasopharyngeal carcinoma, Burkitt lymphoma, and gastric adenocarcinoma. And the EBV, the diagnostic test is monospot or heterophil antibody test. The group of streptococci is mainly causing pharyngitis or tonsillitis, but the complications include acute rheumatic fever, scarlet fever, post-streptococcus glomerulonephritis. Then there is PANDAS, which is analysis pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection, and there can be reactive arthritis as well. So this is a bunch of things happening with group A streptococci. We have seen scarlet fever already. We'll see acute rheumatic fever, PSGN when we discuss nephrology, and can cause reactive arthritis as well. Antibiotic management of bacterial meningitis. We have seen this in neurology, but we'll just recollect what we have studied. So in the initial period, it is mainly ampicillin and cefotaxime. We don't give ceftriaxone in very young children. The main organism are Listeria, E. coli, and GBS. 20 to 90 days, there is overlap of neonatal and those with older children. Mainly in older children, we have streptococcus pneumonia and Neisseria meningitis, which is also seen in adults. Along with that, we have H. influenza. So the treatment of choice is ceftriaxone plus vancomycin. If they are penicillin allergic, you can give vancomycin plus rifampicin, because penicillin allergic people usually have cross allergy to cephalosporins as well. Okay. So in very young children, you can avoid ceftriaxone and give cefotaxime with vancomycin. In the first 30 days, you can give ampicillin plus cefotaxime. A bit of ENT, malignant otitis externa caused by Pseudomonas. You can do a CT skull base to diagnose it. The most definitive diagnosis is by biopsy. The treatment of choice is ceftazidime.
Now, retropharyngeal abscess, which also we have seen when we discussed previously, it is a deep neck space infection caused by group A beta hemolytic streptococci. The definitive diagnosis is by CT, and the treatment is by IND with the antibiotic coverage using ampicillin. We'll just see the difference between retropharyngeal versus peritonsillar abscess as well. Retropharyngeal is usually from 6 months to 6 years, that is younger children. Peritonsillar is a bit older, more than 10 years. There is a history of acute onset high fever with sore throat, muffled hot potato voice, trismus, drooling, cervical lymphadenopathy. It is usually unilateral. A mass may be seen in the posterior pharyngeal wall on inspection. A uvula may be displaced also. In peritonsillar also there is hot potato voice, sore throat, trismus, drooling, and uvula displaced to opposite side. The pathogen is group A streptococcus in retropharyngeal as well as peritonsillar, which is the most common. Others like Staph aureus, Bacteroides, and Robs all can be there. In the child prefers to sit supine with neck extended. Okay, and the diagnosis is by on lateral X-ray. There is soft tissue plane, uh, which is less than 50% of the width of the corresponding vertebral body. Contrast CT helps to differentiate abscess from cellulitis. Treatment is with IND along with ampicillin. Again, for peritonsillar abscess, IND with tonsillectomy and antibiotics. Okay, so that was the